Hello and welcome. My name is Elizabeth Wade, and I have shared a short summary of my professional background at the end of these slides. The title of this presentation is Multiple Risk Reduction Strategies, Case Study Number 1. This is the relevant financial relationship disclosure for this presentation. This is the learning objective that will be addressed during this presentation. These are the key abbreviations that will be used during this presentation. Hey, now it's time to practice. In this presentation, we're going to review a case. You're going to identify the factors that contributed to the medication error. For that error, you're going to be providing an example of each type of risk reduction strategy tool. And for each risk reduction strategy example that you identify, I'd like for you to identify the risk reduction principle associated and any unintended consequences that you might think of. The case we're going to discuss takes place in an ambulatory infusion center. In order to understand the case and the context of the error, I'm going to give you some background on the organization and how the ambulatory infusion center medication use process works. In this infusion center, paper orders are sent by the infusion center staff to the pharmacy by 4 p.m. the day before the patient's appointment. This is so the pharmacy can ensure there's adequate inventory supply available for patient arrival. The overnight pharmacist enters the orders into the pharmacy system for the infusion center after the accounts are activated for the day, around midnight. Upon patient arrival, the infusion center notifies the pharmacy to prepare the product. The product is prepared in a sterile compounding environment where medications are placed in patient and order-specific bins for preparation and checking. The pharmacy then hand delivers these very expensive medications to the infusion center. The ambulatory infusion center then uses barcoding on medication administration and an electronic medication administration record that interfaces with the pharmacy system. In this case, the infusion center sends an order for a patient to receive rituximab 375 mg per meter squared IV piggyback once a week for 4 weeks. The order also includes infusion and titration information. Based on the patient's information, the pharmacist entered the order at 6:09 in the morning for rituximab 700 mg to be prepared in 500 ml of normal saline. The technician preparing the rituximab thought he or she saw infliximab on the label and obtained infliximab vials to fulfill the 700 mg dose. The technician prepared the infliximab 700 mg in 250 milliliters of normal saline, which is the standard volume and diluent for infliximab. The pharmacist checking the product did not notice the discrepancy in the drug or total volume against the patient-specific label for rituximab 700 mg in 500 ml. Of course, in the actual scenario, the checking pharmacist would receive some empty infliximab vials to check along with this rituximab product. But you can see that the total volume on the right-hand side show that there is a total volume of 500 milliliters. And you can see when looking directly above the label that this is a bag of normal saline 250 ml. The pharmacy delivered the rituximab bag containing infliximab to the infusion center. The nurse administering the rituximab didn't notice the discrepancy in volume at first. Per usual policy and procedure, the nurse barcoded the patient's specific pharmacy label, which was correct. The nurse started the infusion. 3 hours later, the infusion pump alarmed. The bag was complete much earlier than expected. Upon further inspection, the nurse noticed that the volume was 250 ml rather than 500 ml. After notifying the pharmacist, the infusion center returned the bag to the pharmacy, and everyone was under the assumption that perhaps the rituximab was prepared in the incorrect volume. You can see in the screenshot below the information from the infusion pump on the administration of the medication and the nurse's documentation that the medication was mixed in 250 ml, not 500 cc's. When the bag was returned to the pharmacy staff thought it was strange because they thought they had prepared only infliximab that day. They did not remember preparing any rituximab doses. Upon looking at records of what was pulled from stock, it was discovered that the bag was prepared using infliximab, and no rituximab had been pooled for that day at all. Fortunately, in this case, the patient suffered no untoward effects. The patient's labs were followed very closely following this event. Remember, as we look at contributing factors and risk reduction strategies, we want to look at each step in the medication use process. In this case, a provider orders rituximab infusion using a paper order. Next, a pharmacy technician checks rituximab supply to ensure enough is available to prepare the dose. After that, a pharmacist enters a rituximab order into the pharmacy computer system. A second technician then manually pulls the infliximab and prepared the dose instead of rituximab. A pharmacist checks the preparation of the rituximab order with the infliximab vials in the bin. The nurse administered the medication after utilizing barcode verification of the pharmacy patient-specific label. There are a lot of contributing factors to consider here. One contributing factor is that in this organization, infliximab is ordered with far greater frequency in the ambulatory infusion center compared to rituximab, resulting in some confirmation bias of the pharmacy staff. Another factor is that infliximab vials are readily available in the sterile compounding area for this reason. Someone has to go outside of the immediate compounding area to pull rituximab from the main pharmacy supply area in order to prepare the dose. A third factor is that turnaround time for preparation is short and the workload is high due to the need to hold the preparation until the patient physically arrives on site. This results in unnecessary rushing. Another factor is that pharmacy labels don't have tall man lettering. Rituximab and infliximab are a look-alike sound-alike pair and were not adequately differentiated. And finally, having barcode verification of the pharmacy label provided the nurse with a false sense of security. We're going to break down all those contributing factors into 3 basic errors that make up this case. The first error being that the pharmacy technician pulled the infliximab for preparing a dose of rituximab. The contributing factor here is that infliximab and rituximab are a look-alike sound-alike pair, with infliximab being prepared with greater frequency. The cause is confirmation bias when reading the pharmacy label. The second error that we want to address with risk reduction strategies is when the pharmacist checked the infliximab vials for a bag labeled as rituximab. Again, infliximab is prepared with far greater frequency. Infliximab and rituximab are a look-alike sound-alike name pair, and the pharmacist also displayed confirmation bias when reading the pharmacy label. And finally, the third error that occurred in this case is that the nurse did not notice the incorrect volume. Barcode medication administration of the pharmacy label gave the nurse a false sense of security. Nurses and barcoding may not detect errors made by the pharmacy during sterile compounding. Now we're going to jump into the practice exercise. Here is where you're going to review the case and identify the factors that contributed to the medication error. For this error, I'd like you to provide an example of each type of risk reduction strategy tool. And for each risk reduction strategy example that you come up with, please identify the risk reduction principle and unintended consequences. As a reminder and a reference, here is the hierarchy of effectiveness of risk reduction strategy tools. The slide on the 4 risk reduction principles has also been provided here as a reference. Now you'll want to access the case worksheet. The case worksheet is going to list out all the different risk reduction strategy tools. Next to each tool, you're going to list an example, what risk reduction principle this covers, and any unintended consequences of that risk reduction strategy that you can think of. For this case, a forcing function could be sterile compounding workflow technology that does not allow a user to proceed without barcode verifying the ingredients and diluents used to make the preparation. This would make any error in selection of the product more visible. However, there are some unintended consequences of doing this. There's a really high cost to technology. There's a lot of resources that it would take to implement this workflow solution, and there are significant workflow changes that would be involved for sterile compounding. Barriers and fail-safes may also include barcode verification. The actual act of barcode verifying itself can be a fail-safe because it would prevent someone from proceeding if there's any error in selection of the ingredients or the diluents. This would make the error more visible and would have the same unintended consequences as the actual workflow technology discussed in forcing functions. A barrier, or a soft forcing function, could be removing common medication vials from the sterile compounding area. This could reduce the likelihood of a selection error, but obviously would increase workload and make workflow changes that might be more difficult to implement, and it may or may not actually decrease the risk of confirmation bias. Having technology in the sterile compounding room that takes photographs of medications used to prepare the medication dose will help make the error more visible. There's also a high cost of technology here as an unintended consequence. Furthermore, someone could still have confirmation bias of the product at hand and see what they want to see even with the photographs taken. It's certainly not a bad idea if there's not already a standard protocol in place for the preparation and checking of infusion center medications to have one. This would reduce variation and therefore reduce the likelihood of an error to recur. There are very few unintended consequences of this other than that a standardized protocol alone would not be very effective long-term in reducing the risk of recurrence. There are certainly opportunities for redundancies in the process. We could have redundancies during inventory checks the day before when the supply is sequestered. This could reduce the likelihood of the error but increase workload and the need for more pharmacy storage. We could have the pharmacist checking products prior to preparation of infusion center medications. And certainly this would reduce the likelihood of the error, but increase pharmacist workload. And if there's not a pharmacist readily available in the sterile compounding area, this could result in some delays. For warnings, alerts, reminders, and checklists, we could employ tall-man lettering on pharmacy labeling to differentiate rituximab and infliximab. This would reduce the likelihood of the error, and as we're getting farther down the hierarchy of risk reduction strategies, there's certainly fewer unintended consequences of this. We could also include brand names for the medication on the label to help differentiate the medication names. Of course, if the length of the medication name gets too long, this could start to go off the label and cause readability issues. We could also implement a policy that details more stringent requirements for the preparation and checking of compounded sterile products for the infusion center. This could reduce the likelihood of the error, and if supporting other higher leverage risk reduction strategies, has fewer unintended consequences. Finally, it can't hurt to provide education and information about this error. We can discuss this case at a staff meeting with the infusion center team. This would reduce the likelihood of the error as well. And we could write a newsletter article regarding the look-alike, sound-alike nature of rituximab and infliximab and highlight this error there. So I'm sure you came up with a lot of great ideas too, perhaps many in addition to the ones that I gave you as examples. What did we ultimately choose to do? Well, we broke up the implementation strategy into several phases. In the first phase, we did the easiest things that we could accomplish with the fewest unintended consequences. So we removed common medication vials from the sterile compounding area. We discussed the case at the meeting. We wrote a newsletter article, implemented policy requirements regarding preparation and checking. And during the inventory checks the day before, we did have a pharmacy technician sequester the supply and label the supply for patient-specific medications so that there would be an independent double check in the process. The second and third phases required some information system changes. So in our second phase, we implemented some easier changes, such as implementing tall-man lettering to differentiate rituximab and infliximab in all pharmacy and clinical care unit locations. We also included brand names for medications on the label. And finally, in phase 3, which this, by the way, happened years later, we implemented sterile compounding workflow technology that did not allow barcode verification to be bypassed. It also included photographs of the products that were used. In conclusion, when we evaluate medication errors in an effort to prevent similar errors in the future, we need to consider each risk reduction strategy for the strength of the strategy, whether it's high, medium, or low leverage, any unintended consequences that that strategy has, and the feasibility for implementation in the organization at the time. Thank you very much for your time and participation.